The American Brain Tumor Association is pleased to welcome you back to our webinar series. Our webinar today is going to discuss neurocognitive issues related to children's brain tumors. My name is Jennifer Westland. I'm the Associate Director of National Programs and Services here at the American Brain Tumor Association, and I'm really delighted to introduce our speaker today, Dr. Heather Conklin. Dr. Conklin earned a bachelor's degree in biology and psychology from Duke University before earning a master's and doctoral degree in clinical psychology from the University of Minnesota. She is currently a pediatric neuropsychologist and associate faculty member in the Department of Psychology at St. Jude's Children's Research Hospital in Memphis, Tennessee. And she's also chief of the newly created section of neuropsychology. Dr. Conklin dedicates the majority of her time to clinical investigation with additional time spent in the provision of clinical care and training of future neuropsychologists. The overarching goal of her research program is to mitigate cognitive deficits following treatment for childhood cancer. She has over 40 peer-reviewed publications and has received extramural funding from both the American Cancer Society and the National Cancer Institute to support this line of investigation. So with that, I'm so happy to introduce Dr. Heather Conklin. You may now go ahead and begin your presentation.
Thank you. Thank you so much for that introduction. And thank you all for participating in this webinar this afternoon. I apologize if I sound a bit congested. Unfortunately, Memphis seems to have been hit by a full-blown attack of pollen in the last couple days. So today, as mentioned, I will be talking about a topic that's of high personal interest for me, that of cognitive late effects experienced by some childhood cancer survivors, as well as the development of interventions to address these issues. I would like to begin with a schematic as a talk overview. First, I'm going to very briefly define the problem of cognitive late effects and then spend some time discussing three main categories of research-supported interventions: that of pharmacologic interventions, therapist-delivered cognitive remediation, and computerized training. Finally, I will spend a little time talking about recent findings in the literature to suggest that physical exercise might offer cognitive protection or benefit. As many of you likely know, children who have received central nervous system-directed therapy for the treatment of cancer are at significant risk for cognitive deficits secondary to disease factors, so the mass effect of the tumor itself, as well as potentially obstructive hydrocephalus, as well as treatment-related factors such as surgical interventions, chemotherapy, or radiation therapy. It's been shown that these deficits are prevalent, with estimates ranging from anywhere from 30 to 80% of the survivorship population, depending on the risk factors in the study sample, as well as the cognitive skills that are assessed. And it's also been shown that these deficits are associated with a reduced quality of life, including academic problems, high rates of unemployment as adults, and a decreased likelihood of living independently. Survival rates for children treated for brain tumors have improved quite significantly in recent years, such that our efforts to optimize long-term cognitive outcomes really take on added importance. Longitudinal studies have most consistently revealed declines on global cognitive measures, so measures of intellectual functioning or academic skills. And it's likely that these declines reflect a decreased rate of learning compared to a child's healthy peers, rather than an actual loss of previous acquired knowledge. So children, after receiving their treatment for brain tumors, continue to learn new skills and don't lose previously acquired knowledge, but their rate of learning new skills is slower than their healthy peers, such that the gap between them and their healthy peers tends to widen over time. So those of us who do assessments refer to this more as a standard score than a raw score decline. Risk factors for cognitive problems have most reliably included having a younger age at treatment, being further out from treatment, again, the widening of that gap over time with healthy peers, having higher treatment intensity, for example, a higher radiation dose received, female gender, and complicating medical factors, such as having experienced meningitis or a vascular event such as a stroke. Historically, there's really been an over-reliance on global cognitive outcomes in the existing literature, so focusing more on IQ or academic achievement. And really greater specification of cognitive impairments is needed, both for isolating those neural systems that are vulnerable, as well as developing targeted interventions. So when we just focus on things like IQ, that can decline for a number of reasons, say, for example, having attention problems or being a slow processor or having difficulty understanding or expressing yourself using language. We don't understand what brain regions are involved, nor do we know how to target our interventions. So more recently, findings have begun to suggest more specific areas of deficit that include attention, working memory, and processing speed. And it may be that these core specific deficits are actually more proximal or closer contributors to these global declines on measures like intellectual functioning. Those of you who are less familiar with the topic of working memory, this is the real active form of short-term memory, your mental sketch pad, if you will. And the most commonly provided example is when someone rehearses a telephone number over and over in their head so as to be able to dial it without writing it down. These emerging areas of cognitive deficit are really informative, as we know that nearly half of age-related improvements in IQ can be attributed to developmental improvements in working memory and processing speed. So even in healthy individuals who are developing, we know that a lot of the improvement in IQ with age relates back to improvements in working memory and processing speed. Therefore, these core areas may really be the culprits for the IQ decline that's been observed. It's important to realize that even if we fully optimize cancer-directed treatment, there remains a risk for cognitive deficits for childhood brain tumor survivors that relates back just to the tumor mass effect itself. Further, with certain treatments, such as surgery or radiation therapy, we will reach a point or a physical plateau in our ability to limit treatment while still maintaining high survival rates. So for example, a large part of our program of research here at St. Jude is decreasing our radiation dose margin. So using a smaller and smaller margin around the brain tumor itself to spare more healthy surrounding tissue. There will be a point at which we can no longer shrink that margin and still maintain our high survival rates. Therefore, it's really important that we work as investigators and clinicians to develop interventions that lessen or mitigate the late effects of both the brain tumor disease itself and the treatments that are received. Yet, there have been relatively few systematic attempts to develop interventions for childhood cancer survivors. So I'm going to switch now to our first area of interventions that I'm going to review, and this is going to be a discussion about pharmacologic interventions. And this is the area that's really received the greatest amount of research attention. So we know that the efficacy of stimulant medications, so medications such as Ritalin or Adderall that serve as dopamine agonists, is well established for improving attention in otherwise healthy children who've been diagnosed with attention deficit hyperactivity disorder, or ADHD. However, we can't just generalize these findings to cancer survivors because the response rate or the tolerance level may differ for these children secondary to having a compromised neurologic status. And really, the evidence for the efficacy of stimulants such as methylphenidate, which goes by the trade name Ritalin, for childhood cancer survivors was really mixed based on preliminary studies. However, these studies tended to be limited in design. They tended to have small sample sizes, poor sample characterization with respect to diagnosis and treatment history, and they tended to use non-optimal dosing. Further, these studies tended to lack appropriate controls without any placebo-controlled trials or crossover trial designs. The first randomized control trial in childhood cancer survivors was conducted at St. Jude by Thompson and colleagues. And they enrolled 32 survivors of either childhood brain tumor or acute lymphoblastic leukemia, ALL, that were selected specifically as having attention and academic problems. And then they randomized them for half to receive a placebo, which is an inert medication, or methylphenidate, and they used 0.6 milligrams per kilogram. So this is a pretty adequate or moderate dose of methylphenidate. And what they found was that there were improvements in the group who received the methylphenidate on measures of attention, such as Connor's continuous performance task, but not on verbal list learning tasks, nor on measures of visual auditory association. Further in this study, they did not look at sustained response. This was just a single dose challenge that they used, nor did they include measures of response in the naturalistic, say the school or home environment. They just stuck with laboratory measures. So this was encouraging, but there was more work to be done. Which leads us to a large multi-site, multi-phase methylphenidate trial that was conducted here under my supervision for the past 6 years, but was a trial initiated by the late Ray Mulhern that we refer to as MEMFX, or MEMFX2. I'm going to walk you through this flow chart here so as not to be overwhelmed, starting up in the upper left-hand corner. So what happened in this study was first we had what we called our screening phase, and that started with 469 brain tumor or leukemia survivors that we screened to find individuals with adequate global IQ functioning who also were experiencing significant attention problems and learning difficulties. Those who qualified and agreed to move forward went on to our in-lab phase. And this was a 2-day in-clinic trial that was double-blind, meaning that neither the participant nor those assessing them knew whether they had received methylphenidate, and it was a crossover. So everyone had 1 day of placebo and 1 day of methylphenidate in a randomized order. Those who were shown to tolerate the medication were then offered participation in the next phase in purple, which was the home crossover phase. And this was a 3-week home-based study. Again, it was double-blinded, so neither the child or the family nor the examiners knew whether the child was getting the medication or placebo. And this time there were 3 weeks, 1 with placebo, 1 with a low dose of methylphenidate, and 1 with a moderate dose. And we looked at attention modulation as well as social skills using both parent and teacher ratings. For those children who showed some medication benefit, the next step was a year-long maintenance phase. This was an open-label trial in which we received both parent and teacher ratings at 1, 3, 6, and 12 months, and then brought the child back into our clinic in order to repeat the cognitive measures from screening. Those individuals that were screened but did not participate in other phases of the study were offered participation as a 12-month cancer control group. So this is a similar group of cancer survivors but who were not receiving methylphenidate at any point in the study. So these slides here show some of the results from the home crossover phase. As a reminder, this was the 3-week randomized double-blind phase that had both a low dose, a moderate dose, and a placebo week. And what we can see is on the Connors rating scale, so these are rater measures of attention, that parents that are represented by the set of graphs on the left and teachers, which are represented by the graphs on the right, both reported a significant improvement for both the low dose and the moderate dose of methylphenidate over placebo for inattentive problems, which are represented by the first 3 bars on the left, as well as for the ADHD index, which are the 3 bars towards the right of each graph. Teachers also reported a reduction in symptoms of hyperactivity, which is the middle set of bars. So during our 3-week home crossover then, both parents and teachers found benefit for both doses of methylphenidate for inattention and ADHD symptoms, and teachers additionally reported a reduction in symptoms of hyperactivity. On the social skills rating system, teachers, again represented by the graph on the right, reported a significant improvement with both the low and the moderate dose of methylphenidate with regard to social and academic competence. There was also a significant improvement for behavior problems, but only with the moderate dose represented in purple in the middle 3 sets of bars. Parents, represented by the graph on the left, did not report a significant improvement on the social skills rating scale for either methylphenidate dose, which could be related to a limited sample of observed social behaviors during a week. So parents probably don't see their child around peers very frequently in just a 1-week period of time in the evening. I should note that for none of these measures was there a significant advantage for the moderate dose of methylphenidate over the low dose, which is relevant when we talk about side effects. So with respect to side effects, and this again is still during that 3-week home crossover phase, what we found is that there were a higher number of symptoms represented by the 3 bars on the left, as well as a higher severity of symptoms represented by the 3 bars on the right, endorsed both for the moderate dose relative to the placebo, which is represented by the gray middle bar, as well as the moderate dose versus the low dose, which are the purple bars to the right. In contrast, there was no significant difference between either number or severity of symptoms endorsed for the low dose relative to the placebo, which are the teal bars on the left. So even though we're seeing more side effects being reported and higher severity of side effects being reported for the moderate dose relative to placebo and the moderate dose relative to the low dose, there was not an increase in symptoms or severity of side effects for the low dose relative to the placebo. And as I just mentioned in the previous slide, there was similar efficacy for low dose and moderate dose, suggesting that lower doses might be optimal for this population. It's also interesting to note that the rate of side effects experienced by our cancer survivors was similar to or less than that reported on the same measure in the ADHD literature. So we were not seeing a higher rate or more severe side effects for our brain tumor survivorship population. And leukemic survivorship population. We did look to see if there were factors that would predict those individuals more likely to have side effects, and in fact, that was individuals who had a brain tumor diagnosis, who were a female gender, or who were treated with higher intensity treatments. So I'm turning now to the year-long maintenance phase, the open-label trial of this multi-phase, multi-site study. And what we're looking at here are parent report of attention abilities over the course of the year-long trial, with the teal or blue lines representing those children who were receiving methylphenidate, and the pink or magenta line indicating those children who were our cancer control group. And what you can see is that parents reported a significant reduction or improvement in attention problems for both the children who were receiving methylphenidate as well as our controls who were not receiving methylphenidate over the course of the year-long trial. In contrast, when we looked at our teacher ratings using a similar measure, we found that only the methylphenidate group in the teal or blue color showed this improvement or reduction in attention problems based on teacher report. Likewise, when we asked the children and adolescents themselves to report on it, it was the same pattern. Only those individuals receiving methylphenidate reported a significant reduction in attention problems. That is not pictured here. When we looked at performance on a computerized measure of sustained attention, the Conners Continuous Performance Task, what we found again is that only the methylphenidate group, represented in the blue, showed significant improvements on this performance-based measure of attention. So just to summarize, for this year-long maintenance phase, we see teachers and self-report of the children and the computerized measure of attention all only showing improvement for the group receiving methylphenidate relative to the control group, whereas parents reported an improvement for both groups, which suggests that there might have been a parent reporting bias of reduced symptoms, which could reflect either an accommodation of parents or getting used to the problems that their child is experiencing over time, with the lack of a peer benchmark, because teachers always have that benchmark of all the same age peers in their classroom, or perhaps there was a bias for study entry. So parents knew when they were filling out these measures at baseline that this would determine whether their child would be entered into the study or not. So maybe there was a pulling or a bias for them to report more problems at that time. Okay. Unfortunately, during the year-long phase, when we looked at our measure of academics, there was no significant gains in either the group receiving methylphenidate or the control group. I should mention that the academic measure used here was a measure of skills such as single word reading or math calculation. And anecdotally, when we spoke with the parents of these children throughout the trial, they often reported that the children were getting better grades in school. And when we probed further, what we found out was that children taking methylphenidate tended to remember to turn in their assignments more readily and remember to plan further out in advance for things like tests and long assignments, suggesting that in future trials we really need to look more at these executive or strategizing aspects of school performance. Okay, so in addition to attention and social skill outcomes, we were also interested in looking at whether there were any adverse medication effects on growth for this population, knowing that would be a concern. So here in these graphs, we report on 51 patients who completed the year-long open-label maintenance trial. They're represented by the solid lines, as well as 51 case-matched controls who are represented by the dotted lines. And what we did was systematically case-match on factors that might be related to growth, including their diagnosis, where their tumor was located, their treatment intensity, gender, race, age, and whether they were receiving hormone replacement. And then we took height and weight measurements from all their clinic visits here at St. Jude, and we converted them to gender and age-corrected Z-scores based on the Center for Disease Control normative data. And what we found is if we look at the top graph, which is reporting specifically on weight, is that both groups, both the group receiving methylphenidate as well as the cancer control group, showed a significant increase in weight. The lines are moving upwards, an upward trend, in time preceding the start of the methylphenidate trial, which the start of the methylphenidate trial is represented by that vertical line. So at the start of our methylphenidate trial, both groups of cancer survivors had weights that were almost a standard deviation above their healthy same-age peers. And there was a significant decline in weight only in the group that received methylphenidate during that year-long trial. When we looked at what predicted a change or a reduction in weight in the group receiving methylphenidate, it was a higher dose of methylphenidate as well as higher parent-reported medication side effects such as loss of appetite. Those are what were associated with the decline in weight. When we look at the bottom graph, that one is focusing specifically on height. What we can see is that for both groups, the lines are flat, meaning that they are similar height to their same-age healthy peers based on the Center for Disease Control normative data, and they're not increasing or decreasing in height over the several months leading up to the start of the medication trial. Likewise, after the start of the medication trial, there was no reduction in height in the group receiving methylphenidate. Okay. So in addition to methylphenidate, there have been other stimulant medications looked at in cancer survivors, including modafinil, which goes by the trade name Provigil and is an alpha-1 adrenoceptor agonist. This has been studied recently in cancer patients, and there are more than 20 published studies looking at modafinil for treating cancer-related fatigue. And what they find is that there's 3 of those 20 studies that also looked at whether there were cognitive benefits in addition to benefits for fatigue, and 2 out of 3 of them reported in adult survivors that, in fact, there were also cognitive benefits. And currently, there are trials open looking at childhood cancer survivors using modafinil, including a trial through the Children's Oncology Group. A newer drug of interest for our cancer survivors is coming from the dementia literature, and this is Aricept, which is an acetylcholine agonist and has been shown in single-arm trials, so not randomized controlled trials, but just everyone getting the agent, to offer attention and memory benefits for adult survivors, as well as evidence for executive function and memory benefits for childhood survivors. So currently, there are multi-site randomized control trials for childhood cancer survivors further investigating the benefits of Aricept. So in summary, in thinking about pharmacologic interventions for our cancer survivors, we can say that findings from our methylphenidate trials are encouraging and reveal an intervention that is beneficial and safe for a significant amount of our cancer survivors. We also can say in rater measures of attention as well as rater measures of social skills. However, we did not find academic gains on standardized measures, but parents did report improved academic grades in school and anecdotally related this to executive aspects of school performance, such as planning for assignments and tests. And these are outcomes that could be better measured in future trials. However, there are also drawbacks to our pharmacologic interventions. It should be noted that children were excluded from participating in these trials for a number of medical contraindications, including uncontrolled seizures, uncorrected hypothyroidism, or a history of Tourette's syndrome. Further, among those who qualified for the medication trial, 36% of parents refused participation, with the most common reason cited being concern about placing their child on the stimulant medication. So suggesting that this method of intervention is not widely acceptable amongst parents of cancer survivors. And while the response rate was encouraging, it was about 45% of the sample showed a significant improvement in attention and social skills when we used a conservative statistical approach. It's lower than what we see in the ADHD population, which is more in the 70 to 80% response rate. And taken together, these findings really highlight the need for non-pharmacologic interventions. So I will switch gears now to talk about non-pharmacologic interventions and specifically cognitive remediation approaches to late effects. The most systematic non-pharmacologic approach to cognitive remediation in survivors of childhood cancer has been developed by Bob Butler and Donna Copeland. These researchers have developed a tripartite model that they call Cognitive Remediation Program, or CRP, It borrows techniques from 3 different schools of intervention. First, from brain injury rehabilitation, they use strategies such as mass practice, which includes repetitive exercises targeted at sustained, selective, and divided attention. They also use strategies from special education, including training in metacognitive strategies such as task preparedness and task monitoring. And they use strategies from clinical psychology, such as using cognitive behavioral therapy approaches, such as helping the child to reframe their cognitive struggles in a more positive light, or monitoring that negative internal dialogue that sometimes children engage in when frustrated. CRP requires participants to complete 20 2-hour one-to-one sessions over 4 to 5 months. Butler and Copeland have recently completed a multi-center randomized controlled trial of cognitive remediation program in 161 survivors of childhood cancer, and St. Jude was a site in this study. All of the participants in this study were identified as demonstrating attention problems. And what they found was that CRP participants experienced a significant improvement in academic achievement. They incorporated more of those metacognitive strategies in their problem solving, and they showed improvements on a parent-rated measure of attention. However, there were no significant differences between the group receiving CRP and controls on measures of neurocognitive functioning, including attention, working memory, and episodic memory. Further, the effect sizes tended to be small, but to be fair, were comparable to other brain injury rehabilitation programs and psychological interventions. Another study has been conducted by Moore and colleagues, and in this study, they had 57 childhood ALL survivors, or acute lymphoblastic leukemia survivors, that were enrolled, and 32 of those 57 completed baseline, post-intervention, and 1-year follow-up assessments. For this study, participants were randomized to either a math intervention program or standard of care. The math intervention was delivered over 40 to 50 hours across 1 year, and the intervention was based on multiple representation theory, which includes the use of manipulatives. If you look at the graphs here, the left graph shows the intervention group, which is in the darker bars, demonstrating a significant improvement in their calculation and applied math skills at post-intervention. So when you look from the baseline to the post-intervention in the middle, you can see a significant improvement, and that these benefits remained 1 year post-intervention when you look further to the right at the follow-up bars. When you look at the right graph, you can see that there was a significant improvement in the intervention group, again represented by the darker bars, in nonverbal working memory skills that were seen at 1 year post, and were suggestive that maybe training in math has some generalized benefits to other skills, such as working memory. Sunita Patel and her colleagues at the City of Hope have also completed a study doing therapist-delivered cognitive remediation. In their study, they included 12 childhood cancer survivors. However, it should be mentioned that they identified 49 as meeting criteria, with only 31% agreeing to participate in their trial. Further, of 15 who initiated this trial, 3 dropped out and only 4 completed all of the 15 recommended sessions, suggesting that there may have been some issues with feasibility or acceptability. For this intervention, there are 5 components that are in some ways similar to the cognitive remediation program of Butler and Copeland. These 5 different strategies include general problem solving, which is having the child learn to state a problem as well as generate and weigh solutions. Study skills, which is, again, teaching the child how to be prepared for tasks and how to monitor their performance throughout task completion. Information processing, which is teaching things like mnemonic strategies or memory strategies such as chunking and using visual imagery. Reviewing compensatory strategies, which is the old SQ3R method some of us learned in school, which includes survey, question, read, recite, and review. And the last component is collaborative contacts. And this is teaching parents and teachers the strategies that the clinician is using with the child so that they may continue to implement these strategies in the school and home environment, which may offer some of the greatest reach for this intervention. So pictured here is the table from this publication showing their outcomes across a number of cognitive measures in the left column. As mentioned before, their sample size was rather small, but if you look at all the changes over time across measures here they have of academic achievement, attention, verbal learning, and behavior, that you can see the trends are all in the correct direction. And I'm sorry, hold on a second. Something's not working. Okay, anyway, there should have been some highlighting here showing that some of these stats actually do reach significance, including ones with the arithmetic score as well as the writing samples. There we go. Okay, so now if we summarize the findings from these non-pharmacologic therapist-delivered strategies, here's what we find. There are a number of advantages. For example, parents and teachers tend to really understand these techniques, and their involvement may offer the greatest potency because they can continue to work on these strategies with their children outside of the therapist session. And there are no medical concerns or contraindications, as we found with stimulant medications. That said, these interventions also have some drawbacks. They require a very large time investment, both for the providers and the family alike. The benefits tend to be modest when you consider the amount of time investment. And there really are very few centers throughout the United States that offer these types of interventions. So families need to live in close proximity to those centers in order to participate. And the Patel study that I reviewed also suggests that there may be some issues with acceptance of these sorts of strategies. So these findings really point to the need for a less expensive, less time-intensive, and more portable cognitive intervention program. So this moves us now to the third area of computerized training. So computerized training refers to a group of computer software packages that are designed to exercise specified cognitive processes. Most rest on the principle of mass practice with repetition of similar exercises over multiple sessions. And the difficulty of tasks in this computerized program is graded such that they increase or become more difficult as the individual demonstrates success. Many of these programs also require some level of coaching by a trained professional who provides feedback and assists in maintaining motivation. Captain's Log is a computerized training program that has been around since the 1980s. It covers a wide skill set, including attention, working memory, visual motor, and problem-solving skills. I was able to locate 5 published studies with a range of populations, including HIV, cerebral malaria, as well as ADHD. Most relevant to the talk today, there is a recently published pilot study with 9 acute lymphoblastic leukemia or brain tumor survivors that demonstrates feasibility and acceptability to this approach, as well as suggesting some benefits for attention. The primary author on that study, Christy Hardy, has subsequently moved away from using this Captain's Log program because the user interface, if you think back to the 1980s when this was developed, tends to be very simplistic relative to more modern graphics, which led to boredom in some children and noncompliance. There's also no suggested dose of how often, how frequent, how many sessions need to be completed in order to have benefits, and it was very difficult to then standardize administration across a large number of potential tasks. So this brings me to CogMed, which is another computerized training program. And this is one that I am using currently in my research, and Christy Hardy is also using in her research. And we both like because it covers a really wide age range of individuals from 4 up through adulthood. There's lots of details available so that you can administer this remotely and follow an individual's progress over the internet. And there are a number of published randomized controlled trials suggesting benefit that I will review briefly. CogMed is a program that was developed by neuroscientists and game developers at the Karolinska Institute in Stockholm. There are 3 age-based versions that span a large age range. So they have the JM version for age 4 to 6, the RM for 7 to 18, and the QM for adults. And it consists of 30 to 45-minute sessions that are completed each weekday for 5 weeks. The child is guided through 8 different rotating exercises each day, and these train both visual, spatial, and verbal working memory abilities. As the child's ability improves, the exercises become more difficult. And in general, they try to exercise you at a rate of about 50% effort or accuracy. Compliance and performance can be tracked over the internet. So for example, from my computer, if I have people training remotely, I'm able to see when they log on, what order they do sessions in, when they get ones wrong, when they take breaks, how taking breaks improves their performance, etc. So a lot of information that we can see remotely on the internet. And then feedback is provided during weekly coaching sessions in order to troubleshoot any problems they may be having, as well as to help maintain motivation. Pictured here on the slide is one task within CogMed referred to as asteroids. And in this task, these asteroids light up in a random specified order while the asteroids are still rotating through space. And the child must remember or hold in working memory the location of those asteroids in space so that when it's their time to respond, they click on them in the order in which they were lit up. Okay. So there's quite a bit of emerging research to support CogMed use with different populations, and results from randomized controlled trials indicate that CogMed has efficacy for improving both working memory as well as more general executive functions like planning and organizing and strategizing in a range of different populations, including children diagnosed with ADHD, healthy children who just have specific working memory problems, as well as adult stroke survivors. There's also some evidence to suggest that benefits are maintained 6 months after training. And there's findings from 2 different functional magnetic resonance imaging, or fMRI, experiments with healthy adults that both converge in identifying areas of increased brain activity from pre to post-training in the areas indicated in red, which includes the middle frontal gyrus, superior and inferior parietal cortices, and that these changes or increase in activation from before to after training also correspond to improvement in working memory performance, suggesting that there is some cortical plasticity. So not only are we seeing behavioral changes, but it suggests that there are brain-based changes with training as well. Christy Hardy and collaborators at Duke have conducted a trial to assess feasibility and acceptability of CogMed for childhood cancer survivors. They enrolled 20 participants, with 13 randomized to the adaptive and 7 to the non-adaptive condition. Non-adaptive means that they keep training at the same level of difficulty. It never gets more than 2 or 3 items they have to hold in working memory. And what they found was that there was a high acceptance rate. 85% of participants were compliant with training, doing at least 20 of the recommended 25 sessions. And there was a high rate of session completion, with an average of 24.5 out of 25 sessions completed. Likewise, there was a high rate of satisfaction reported by parents, with the majority indicating that children enjoyed training. These are graphs from that study. What you can see is after controlling for estimated IQ and baseline performance, the adaptive intervention group improved significantly in symbolic working memory. This is in the top graph. And you can see that there was a trend to maintain those benefits at 3 months. Likewise, if you look at the bottom graph, you can see that parents of participants in the adaptive intervention also reported a significant decrease in learning problems that was unfortunately not maintained when you looked 3 months out. So these findings did offer some preliminary support for the benefit of this program with childhood cancer survivors, yet the study was not large enough to be powered to look at efficacy, and they didn't look at brain-based or neurocorrelates of change using functional imaging. We are currently funded by the American Cancer Society for a study looking at CogMed, where we're using a single-blind design, so our examiners who do the testing of their children don't know whether or not they're getting the CogMed intervention. Children are randomized either to CogMed or to our standard of care. We're recruiting patients who are treated for either a brain tumor or leukemia, who we screen and identify as having working memory problems. Both groups, both the group getting CogMed and the control group, complete cognitive evaluations both pre- and post-intervention, as well as 6 months later to look at maintenance of benefits. And for the children that are randomized to the CogMed intervention, they are getting functional or fMRI studies to look at brain-based changes both pre- and post-intervention. Those individuals who are randomized to our standard of care control group are then offered the CogMed intervention off study after completing their post-cognitive assessment. At this point, we've now completed enrollment for the study. Everyone has completed their immediate post-training assessments, and 6-month post-training assessments will be completed sometime this summer. I'm not at liberty to give specifics about the results, but the findings are encouraging overall thus far. Kessler and colleagues at Lumos Labs have been developing a different web-based computerized program called Lumosity, and they have conducted a single-arm pilot trial with a battery that consists of 40 sessions targeting cognitive flexibility, attention, and working memory. They enrolled survivors of leukemia and brain tumor between 7 and 19 years of age. They enrolled 23 with 19 or 83% completing their curriculum. And they found that survivors demonstrated significant improvement in processing speed, cognitive flexibility, visual and verbal memory. However, there was no significant improvement in attention or working memory. They did conduct functional imaging, or fMRI, pre and post this intervention, and they found a significant increase in activation within the dorsolateral prefrontal cortex that occurred with training. So in summary, when we think about these computerized interventions, benefits include the ability to standardize as well as titrate or systematically increase the difficulty, which is particularly beneficial for research designs. Also, the programs can be administered remotely, extending reach to individuals that don't live in close proximity to providers. The time burden is reduced relative to clinician-delivered interventions, and there are few medical contraindications, the only one really being photosensitive seizures. However, there are drawbacks. Those that are available for clinical use, such as CogMed, are relatively expensive without insurance coverage. Some individuals may lack the requisite technology, although we found even here down in Memphis that that was pretty limited. Most people had the computers and internet service required to run these programs. And the generalizability, or the ability for the skill benefits to generalize to more functional and academic skills, has not yet been widely demonstrated. But there are studies currently in progress looking at the generalization to non-trained skills, looking at the maintenance of benefits over time after completing the intervention, as well as using neuroimaging to identify neural mechanisms for change. So this brings me to the last area I'm going to briefly touch on, and this is physical exercise. I'm just learning this literature myself, but I am excited by some of the potential applications. So I think that all of us recognize the medical benefits of physical exercise, including decreased risk for cardiovascular, metabolic, and metastatic disease. However, the cognitive and brain-based benefits are less appreciated, with emerging evidence to suggest that there can be, with physical exercise, there can be improvements in learning and memory, delayed age-related memory decline, both with healthy aging as well as in the case of neurodegenerative disease. There can be promotion of recovery using physical exercise following an acquired brain injury, such as a traumatic brain injury or stroke. And there can be mood enhancement with physical exercise or antidepressant effects. Among studies that have been conducted with humans, there have been relatively few with children, and so far none published with childhood cancer survivors. That said, while the literature causally linking exercise to cognitive benefits in humans may be in its early stages, there is a large literature demonstrating benefits in rodents, including benefits such as improved spatial memory, reduced age-related memory declines both in normal rodents as well as transgenic mouse models of dementia, exercise-induced increases in the production and survival of new neurons in the hippocampus, which is a brain area very important for memory. And these studies really provide important clues regarding what the mechanism might be for improved cognitive outcomes. So there's evidence to suggest neurogenesis, or the formation of new neurons or brain cells, increased synaptic plasticity, or more connections between your neurons, angiogenesis, or new blood vessel formation, as well as enhanced function of neurotransmitter systems. There are two studies that have investigated the potential benefits of exercise in mice that are irradiated or who receive radiation therapy. Naylor and colleagues irradiated male mice at postnatal day 9, which they indicate corresponds neurodevelopmentally to humans less than 3 years of age. And they used what they deemed a clinically relevant dose of 6-gray whole brain irradiation. And then at 9 weeks, they introduced a running wheel to half the animals. And 4 weeks later, they conducted behavior testing in an open field paradigm. What they found was that irradiation did result in a severe loss of proliferating cells in the dentate gyrus, as well as perturbed integration of cells within the hippocampus. However, by offering this voluntary running, they were able to restore these neurons and neurogenesis after irradiation, and that this resulted to an improvement in the behavior they were measuring in the open field paradigm. There's one other study by Wong and Goodrich. They irradiated 40 female mice at 12 weeks with 5-gray of irradiation. After 4 weeks, they introduced a running wheel, and they trained on something called the Barnes maze, which is a spatial learning task, at 3 different time points. And then they allowed daily running in half the group. And what they found was that that daily running prevented a decline that they otherwise saw in spatial memory after radiation, and that this change or improvement in behavior was accompanied by restoration of neurons or brain cells within the dentate gyrus of that hippocampus, that structure that's so important for memory. There is currently a study underway by Don Mabbott at the Hospital for Sick Kids in Toronto, where he started an exercise intervention program for childhood brain tumor survivors. You can see here it's a manualized program. The children complete 3 sessions per week for 12 weeks, and the sessions are an hour and a half in duration. All participants are brain tumor survivors that received cranial radiation and who are between 8 and 16 years of age. It's a multidisciplinary team, including physical therapists, exercise physiologists, and psychologists, and the structure of each session includes a warm-up, followed by aerobic training or fitness games, organized sports, and then a cool-down period and snack and rewards. During this trial, they are gaining pre- and post-assessments of fitness and motor proficiency, as well as cognitive performance and neuroimaging. These results have not yet been formally presented, but is an encouraging avenue of research. And in addition to this hospital-based program that they're using, this group is planning to move this exercise intervention into the community and into the home at places like, say, a YMCA that are more accessible to a greater range of families. Okay, so to summarize the outcomes for physical exercise, we already know that physical exercise is associated with a number of physical and medical benefits. It's relatively inexpensive and easy to implement. And through all these animal models, we know what the mechanisms are in terms of why you might have improved cognition with exercise. That said, there are a number of drawbacks. So far, there's no standardized dose, so we don't know what type of exercise do you need to do, how long do you need to do it, how intensively do you need to exercise to have cognitive benefits. We also know that some of our brain tumor survivors will have physical limitations or motivational challenges to maintaining a cardiovascular exercise program. And it's likely in the end that physical exercise, while it may have cognitive benefits, those benefits probably will be less robust than we see with interventions specifically targeting cognition, such as the other ones reviewed in this talk. So last slide, I want to talk a little bit about future directions. The field is really building momentum within the last decade, but there are still many areas in need of investigation. And here are just a few thoughts from me on where we may be heading. First of all, rather than working just with survivors, which all of these studies have been with long-term survivors who are experiencing late effects, I think we need to be moving to intervene early, more during or shortly after treatment to see if we can avoid issues in the first place. I think we need to be thinking about combining intervention strategies such as medication with coaching or computerized training with exercise to see if we can really optimize our benefits by capitalizing on synergism of different therapeutic modalities. I think we need to be thinking about increasing our reach to more children by offering these interventions in school settings, particularly for individuals in low-resource or rural areas. I think there are ways to take better advantage of technology, including genetics and neuroimaging, in order to identify those children early on, either before or during treatment, who are at greatest risk for late effects, and then intervening early and selecting interventions that match their individualized need. And I think there are potential uses for technology such as EEG or real-time fMRI when you're doing an fMRI and getting feedback and results in real time in order to train individuals to activate or use their brain in a way that most mimics or copies what we see in folks that are good performers of these tasks. So I think those are just some ideas for future directions. I'm sure there are many others as well. And that's all I have for now, and I'd be happy to take questions. Thank you.
Wonderful. Thank you so very much, Dr. Conklin. Lots of great information I'm sure is going to elicit a lot of great questions from folks. We do have time for questions. I'm showing about 10 minutes before the hour, and Dr. Conklin has agreed to try to get through as many questions as possible. We may run over a little bit to try to get through some of those questions. So if you do have a question, you can go ahead and type it in the question area on the right-hand side of your screen. So the first question comes from Eileen in Alabama, and she asks, can brain tumors cause a person's behavior to change from someone who is very kind or gentle to someone who might become abusive? And if so, what is the treatment plan and prognosis for the patient to change?
Okay. I think that's a good question. Of course, we know there's a lot of variability in outcomes in our brain tumor survivors related to things like what their diagnosis is, where their tumor is located in their brain, at what age they were diagnosed, what sort of interventions they needed, if they needed extensive surgery, for example, or chemotherapy or radiation. All that said, we do know that brain tumors in certain brain regions, particularly in frontal or orbital frontal areas of the brain, areas that are near the forefront of your head or near your eyes, that we have seen changes in behavior in individuals who have tumors in those areas or have surgical interventions that affect those brain regions. Those behavior changes can be different based on a particular individual, and we see the full spectrum. So it could be from someone who is, say, very reserved and quiet and soft-spoken to someone who then becomes very disinhibited or rambunctious. It could be a multitude of different kinds of changes. I myself have not seen a lot where I would say they had changed from kind to abusive. That's not a trend that we hear often or see clinically often. But if there is a change in behavior associated either with the brain tumor itself or with the required treatment, I think it's very important to first have that child assessed thoroughly. I would recommend by a neuropsychologist, someone who can look at a variety of functions, things like attention and memory, in addition to personality and mood and anxiety and family factors, and try to best understand what the challenges are, and then work with the family to get the correct services, which may include therapy, which may include medication, which may include certain accommodations within the school setting, or help through vocational rehabilitation, all depending on what's found with that evaluation.
Thank you. The next question comes from Janet in California, and she asks, do you see the possibility of other promising non-toxic therapies becoming available for integrative research?
I do. I think, while the data I showed you for different pharmacotherapies like stimulant medications generally show that these medications in the short term are safe for our cancer survivors in terms of risk for side effects, growth effects, etc. I do hear from the families I work with clinically, both as well as in the research I'm doing, that there are a number of families that would like to use non-pharmacotherapy approaches given vulnerabilities their children might have after their cancer treatment. And so I think that there is a real focus now on researchers to look at things like behavioral interventions, either delivered by a therapist, some of these computerized interventions that are reviewed, as well as things like physical exercise and nutrition and other things that are more extension of what we all try to do as part of our healthy lifestyle. And I think that there's a lot of promising evidence for these non-pharmacotherapy interventions, but ultimately to get the best effect for a particular individual, it's probably going to take a combination of these things. So while our research right now is really focusing on one at a time so that we best understand the benefits and risks, that ultimately combining things like good nutrition, physical exercise, getting school services that you need, taking advantage of computerized exercises to really train these skills, that using all of these in concert are going to give folks the best possible outcome.
Okay, thank you. The next question comes from Barbara, and she asks, what would you suggest for a 19-year survivor who is experiencing attention and memory issues? She says nothing was available back when the original diagnosis was made.
Mm-hmm. I think that's an important question. We certainly know from research populations that have had more research done with them, so for example, traumatic brain injuries you might incur in a car accident, that there does tend to be a period of time during which rehab is going to be more efficacious. So intervening early in the first 6 months to 2 years, you're going to see more beneficial outcomes in terms of intervening. That said, I think even for our long-term survivors, there certainly are things we can do to compensate. So even if we can't change or remediate the underlying skill or problem, there are certainly things we can do to compensate by making different accommodations to the environment, using different tools to help us attend and learn and memorize things that can be used as well. So I do think that a lot of these strategies are still worth trying in a long-term survivor. always, I think, the first thing, given how many individual differences there are, would be to get a really good comprehensive assessment. Sometimes things that appear to be memory problems may be more attention related, because if you're not attending, you can't get things into memory. Or sometimes things that look memory related are more mood related. We know that people who are depressed have a lot of problems with memory. So I think it's very important to first get a thorough evaluation so you really understand what the core problems are. And then if the problems really are in attention and memory, there are a number of resources out there that include some of the medications we've discussed today, as well as some of these computerized training programs like Lumosity and CogMed that are commercially available, as well as just using lots of technology that's out there. So for example, a lot of folks I work with clinically who have memory problems, there are watches available that you can use a USB port, and you can program their whole day into a chip and put it back in the watch. So all day it's telling them when to take their medications, when to go to a certain appointment, when it's got text that comes up on a watch face. So there are all sorts of technology and tools we can use to compensate for attention and memory problems as well.
Thank you. The next question comes from Janvier, who asks, why are deficits severe in early age, and yet brain plasticity would be expected to be better in the pediatric population?
That's a very challenging question, and an ongoing debate in terms of whether it's better to have injury early or later in life, and there's been a lot of disagreement about that as well. So while we do know that neuroplasticity, or the ability of the brain to reorganize or compensate or recover, exists way out into even old age, we now understand the brain is always adapting and recovering. It does tend to be greater in a young brain. But we also know that the brain is more vulnerable at that age because there are so many changes occurring. So for example, we know that one of the primary mechanisms for cognitive late effects is a disruption in what we call white matter, or the myelin in the brain. This is like the insulation for our neurons. And that white matter is still so rapidly developing in early age up until sort of our mid to late 20s. And so children who have a disruption earlier on to that process really suffer greater consequences because their brain is in such a rapid state of development. Further, we know that children who are treated at younger age just haven't been as exposed and haven't mastered as many skills as children at an older age. So for example, we often see kids who have not learned to read prior to their diagnosis and their treatment really struggling with learning to do that afterwards, whereas kids who have learned to read before their diagnosis and treatment seem to hold on to that skill. So while I agree, neuroplasticity occurs throughout the lifespan but is better in young children, we also know that there's a lot of neurodevelopmental events going on at a young age, including this myelination or increase in white matter that might make young children more susceptible to toxicity of their therapies. And just environmentally, they've had less exposure and less mastery of skills, so they have more to learn after their injury with a brain that is learning to cope and adapt differently.
Thank you. The next question comes from Jessica. She asks, is there anything that can be done during treatment to help curb the cognitive effects of chemo and or radiation?
I think that's a great question. I don't think our research has the answers to that yet because, as I mentioned, we've really concentrated on the survivorship period. But I think now that we're demonstrating things are working in the survivorship period, the question is, yeah, why wait? Let's try and do that during treatment. And so there are a number of studies now that are starting or in development that will be intervening either during therapy or immediately after therapy before we're seeing all these cognitive problems emerging. There are some challenges we're seeing to the people who are first doing these studies. So for example, trying to do things like exercise or computerized training when people are feeling very ill from their chemotherapy is hard to get compliance during that time. So there are some challenges during that time, but I think it's worth trying. And I think the kinds of things you would want to do is first make sure you're getting rest, because rest is so restorative, and trying to do everything you can to do to protect sleep and a sleep-wake cycle. Exercising if you're able to do that. Continuing to get academic exposure. So even if you're not in school, having time set aside in the day where you're working one-on-one and working on your academic skills and working on some of these more challenging cognitive processes. So really staying cognitively active during your treatment as well, I think will help to exercise and maintain some of those new connections.
Thank you. I am showing 3 o'clock Central Time, but Dr. Conklin has graciously agreed to stay on the line for a few additional minutes to get to more of your questions. So if you all out there on the line can stay on, we'll continue forward with a few more questions as she's able to answer them. So the next question then comes from Gary, and he says, what about HBOT, hyperbaric oxygen treatment, or niacin to help out with angiogenesis? Can you comment on that?
Yeah, I can tell you I am not an expert in answering this, and Jennifer and I discussed the possibility of me following up and writing after some of these questions because I want to make sure to give you the most recent references for some of these more cutting-edge interventions. So we do know that hyperbaric oxygen therapy is used most often in the context of necrosis associated with radiation therapy. So actually during or soon after radiation therapy when you can see some cell death and imaging that's associated with changes in cognition or motor performance, that often the medical team will recommend hyperbaric therapy and that they can see improvements and a faster rate of recovery after things like that. It's starting to be used more often in the survivorship period to deal with academic and cognitive problems. And clinically, I have some families who have chosen to use this and have claimed that they have benefits from it. But the research really isn't rigorous thus far for using it for cognitive problems during the survivorship period. That's really in its infancy. And so I think it's an interesting question. I can look to see what else is out there on that topic and get back with you. But I always recommend to our families that when you're looking for interventions to really try and first do things and prioritize things that have research support, such as the things I've reviewed today, because those have really been put to the test and shown to have benefits. And then if you have still more time and still more financial resources to try other things, that you try things like this, but always in concert with your medical team's clearance and making sure you're not doing something against medical advice. And that would be my recommendation. But hyperbaric therapy, we know there's evidence to suggest it's beneficial for radiation-induced necrosis early on in treatment. People are just starting to use during the survivorship period for cognitive issues. Clinically and anecdotally, people are claiming benefits, but the research is not quite there yet.
Thank you. The next question comes from Jill. She says, can you talk about accommodations available in high school and college for kids with slow processing speed and short-term memory issues?
Yes. So I think there are actually more accommodations available than families are often aware of, and that one of the best things you can do for your childhood cancer survivor is to become educated and to be a good consumer. And this is another question I can follow up with some references. There are some great book chapters that suggest how to advocate and get these services. But to answer your question in short, the first thing, again, is to get a thorough assessment to document that these problems exist. The next thing is to set up a meeting with your school to develop either what we call an IEP, an individualized education program, or a 504 plan, and that these plans then document what accommodations and modifications should be done within the school setting. And these are then living documents that the team has to implement and has to routinely update and monitor. So it's really important to get that assessment done, to meet with the educational team to develop these plans, and then to make sure that these services are being implemented and that you're continuing to monitor progress to make sure they're working. For the high school student with slow processing speed, so far, we haven't found great interventions to improve that. People have reported that stimulant medications might give a processing speed benefit. The Lumosity program that I reviewed today, they reported in their brain tumor population that they improved processing speed. But for the most part, we're often talking more accommodations than actually rehabilitating processing speed. And so accommodations might include increased time, both for standardized testing, such as ACTs or SATs for admissions to college. You can get documentation and approval to, say, have 1.5 or 2 times the amount of allotted time for that. You can also get increased time for doing tests within the school setting. You can also get increased time for doing large projects, such as book reports, etc. or you can have a reduced load to accommodate for processing speed. So for example, if there's a set amount of math problems that need to be done, doing every other problem rather than every problem, with the idea that you're going for quality rather than quantity in a child who has slow processing speed. In addition to that, when individuals are thinking about going to college, colleges always have an Office of Disability Services. So the first thing to do once you're admitted somewhere, or even if you're looking at and deciding which schools to apply to, is to meet with officials within the Office of Disability Service and ask specifically what types of accommodations they have. Typical things there, because in the college setting you would be under a 504 situation rather than an IEP. Typical things they will do, again, is giving you the increased time, reduced course load, reduced number of projects, but they also often will have things like note takers, where anonymously you can get copies of notes that you're not having to take notes and listen and process information all at the same time. You can also often get paired with tutors or coaches to help with developing memory strategies or mnemonic strategies that might most specifically help you with your problems. And you also can get access to different technologies, so for example, using keyboarding during lectures.
Okay, thank you. We have time for just one more question, which comes from Cheryl, and she asks, is CogMed something that is currently available outside of the clinical trial?
Yes, it is currently commercially available, and you can search on the internet. They have a website for CogMed, and it will explain what's involved with it and review what research is out there showing its efficacy. And what happens is that there are different clinical psychologists throughout the country that become certified providers, and you get matched up with one that would be in your closest geographical area. There is a fee involved. I don't know specifically what it is at this time based on circumstances, and typically that is not reimbursable by insurance. But you get assigned a therapist who, as I mentioned, could do most of it over the phone, but can help set you up with that at home, and you can do it from your home with those weekly phone calls for monitoring. So yes, it is available commercially for payment, usually not insurance coverage, and you can go to the CogMed site to find out about providers in your area.
Okay, thank you so much. We are out of time for questions today. Like Dr. Conklin said, though, offline she'll try to respond to some of the ones we didn't have a chance to get to, and then we'll post what we're able to post on our ABTA website, which you have hopefully in front of you, www.abta.org. And for some of you who joined a little late this afternoon, this webinar is being recorded and will soon be posted. So if you wanted to catch the beginning portion or share the entire webinar with other colleagues, family, friends, you're certainly welcome to do so. I did just want to make one sort of nice parting comment from Kara in Oregon, who says that she didn't get any information on this topic while getting treatment in her teens, and she's often wondered if she had any residual effects from the brain surgery and tumor, and that she was very excited to see a webinar on this subject, and thank you so much for offering it. So Dr. Heather Conklin of St. Jude's Children's Research Hospital in Memphis, Tennessee, I'd like to thank you so much for being with us today.
You're welcome.